now we have a wonderful presentation from Jorge Salazar of Children's Heart Institute at Memorial Hermann. He's going to talk about innovations in pediatric heart surgery, making half a heart whole. This should be really exciting. Let me turn this on.
My name is Jorge Salazar, and I'm a pediatric heart surgeon in Houston. And like most of the people that are listening to this, the most important thing you need to know about me is that I'm a parent. I'm actually the parent of 5 girls and 2 boys. And I love my children desperately, just like I know you love your children desperately. And I have taken that raw instinct, that emotion, because having kids has changed my life. I mean, there's no doubt. I'm forever changed being a parent. I've taken that emotion and that sort of desire to protect my own children, and I have directed that through my profession, through my career as a pediatric heart surgeon, to help other parents like me protect their children and give them the life that we would all want for our children. So fundamentally, it's about giving our kids the best that we possibly can, protecting them, having them do better than us, frankly, and we don't want them to suffer. So when I went into pediatric heart surgery, I had no idea how many children there were worldwide that still weren't receiving care. Kids that, of those 1% of all kids that are born that have a heart defect, there was still a large percentage of them who were thought to have problems that were too complex to fix. And many of you are familiar with the children that are born with half a heart that are called the single ventricle population. There's many, many different kinds of single ventricles, but as you know, they can be grouped together as a single ventricle population. Kids that are traditionally given the Norwood operation or something similar in the newborn period, then they get their Glenn when they're 4 to 6 months of age, and then their Fontan somewhere between 2 and 3 years of age. Those children, not that long ago, didn't have any hope. And then through the Fontan pathway or the single ventricle pathway, our specialty has found hope for those children so that we can give them a shot at a normal life. But as many of you know, and we're all very, have our eyes wide open about this, the pathway of a single ventricle child, and actually for parents as well, is difficult. It's difficult to have half a heart. The physiology is challenging to manage. And even though we as a specialty have gotten much, much better at caring for kids born with half a heart, we do see that some of the children are not able to have normal exercise capacity. They're not able to live a life that maybe the way we were able to live it. Because we were all very lucky, obviously. There were a lot of children who were thought to be so complex, even 15 years ago, that we as a specialty didn't offer them care, or we referred them for transplant, or unfortunately they would pass away in the local nursery without being referred. And I've seen this a lot in my career. And because I had children of my own, I just didn't find this acceptable at a very fundamental level. And so myself, and I'm not the only one, there's a group of us throughout the country and throughout the world who just didn't want to accept these preconceived ideas of the past, the status quo, so to speak. We've spent our careers trying to find new solutions, frankly, better solutions, and hope. And we all know as parents that hope is the most important thing, hope and faith. We back that up with very hard work, determination as a parent, and in my case as a heart surgeon, to find solutions that are just better, so that it's not just about survival, and we all know that, but we always need to aim for 100% survival, never accept failure, and not just survival, but we need to really aim at giving our children the opportunity for a normal life. Because fundamentally, that's what every parent wants for their child. In fact, we want them to have a better life, as I said, than what we had. So to that end, what myself and others have been doing over these last few years is figuring it out. And it's not been experimental, because we don't experiment with babies. We don't take unnecessary risks. But we've taken, our God-given capacity and the cumulative experience of generations now of not just heart surgeons, but cardiologists and critical care doctors and nurses and anesthesiologists, all the people that you've known in your own personal lives with your children. And we've learned, we've evolved, we've gotten better. So we've been able to capitalize on this collective experience of our specialty and these great advances of technology over these now, last 15, 20 years, so that every day, we are performing operations that we were told in training were impossible, that were too dangerous, in fact, that you shouldn't do it. And now that I've operated on 8 or 10,000 babies in my career, I can tell you on the basis of, a lot of data, that those preconceived ideas of the past are no longer true. We can save babies who previously were thought to have no hope. And for those kids with single ventricles born with half a heart, or at least they were thought to be born with half a heart, there's a very big percentage of those children now that we actually do a normal heart repair in the newborn period. We don't accept reality as is. We work, at least at face value, we work with what the child was born with, and we recreate or redirect or rework parts of the heart so that the heart can function normally. And we do this all the time now. I have 2 or 3 babies a week now that are either newborns or older kids. The newborns are ones where we just do the normal heart repair up front. Not all children are candidates for this, but a surprising number are, a surprising number. And we either do the full normal heart repair up front, or for kids that have already been started down the single ventricle pathway, they've already had a Norwood, they've already had a Glenn, or they've already had a Fontan, many of those kids can actually be converted back to a normal heart repair. And the success rate is actually better, because the single ventricle palliation, as it's called, or the single ventricle pathway that ultimately ends in the Fontan, is awesome. It's a great option, especially if there's no other option. It's always better to keep your child's own heart if you can, because transplant, as all of us know, which is a tremendous blessing as well to have transplant available to us, transplant is a new set of problems. It's a different set of problems. And transplanted hearts don't last forever. So our job is to preserve the child's own heart as long as possible and have it function as well as possible, what any parent would want for their child. So in the case of the kids who have already gone down the single ventricle pathway, many of those kids can actually be converted back to a normal heart repair. And we have many, many examples of this being successful. The other alternative, which I actually prefer even more, is do the normal heart repair in the newborn period in one step. The baby's heart, just like the baby's brain and the baby's tissues, are still so plastic in the sense that they can become whatever they want to be. They can, like the baby's brain is just one of the most amazing. But the heart is the same. And if you set up the heart in a way so that the blood does flow to the chambers that were too small, whether it's the atrium or the ventricle, or you want the mitral valve to grow or what have you, it turns out that if you direct the blood where you want the heart to grow, the heart grows. And for all of you that are listening, I'm sure you think that this is complete common sense, because that's actually how the heart forms in the womb. Flow causes growth. And even after we're born, the reason why our hearts grow over time is because the blood's flowing through it. As we get bigger, the heart gets bigger. Well, it's really no magic trick. It's actually just an application of common sense. But we can actually get parts of the heart that are too small to grow. And it's stunning to see this over and over again. Kids who were thought to have a part of their heart that was too small, and therefore they had to go down the single ventricle pathway. Now, there's some things that we can't conjure out of thin air. If the left heart didn't form at all, like in hypoplastic left heart syndrome, obviously nobody's God here. We're not claiming that. So we have not figured out a way to get that left heart to be grown out of nothing. We're working on it. Believe me, we're still working on it. But if a child is born without a mitral valve, it's difficult to implant a mitral valve in a newborn safely. So we haven't figured out a way to grow a heart from nothing, or a part of a heart from nothing, but many, many children have a part of the heart that we can work with, and we can get it to grow. So even though they may start on the single ventricle pathway in the newborn period, we're setting them up for success so that by the time they're at the Glenn age or at the Fontan age, the heart has grown sufficiently where we can actually separate the left and the right sides and give them a functionally normal heart. So I think this is very exciting, and we're just scratching the surface of what is possible. But I come back to the beginning of what. Sorry, can you hear me okay? Okay. I'll come back to the beginning of what I said before. We're all parents. We all know what we would want for our own child. So let's use our common sense, our hard work, and this amazing technology that's available to us. And let's deliver solutions that are frankly just better. I want to do for other people's children what or my wife would want for our children. And we want the very best for them. And I know that you want to do for your children. So thank you so much for this time that you've allowed me to share with you, and really for the trust that you've given us with your children. That is not something that I take for granted. And frankly, I think it's an honor to be able to partner with you for the future of your children. Thank you.
Excellent. So we are going to go for questions. Dr. Salazar, you can turn your camera on if you'd like. And I have a couple of questions. One is, there's a concern, is there a concern, certain period of time after the Fontan that it's ideal for patients to go back and try this, or a period of time that's too far past?
Well, can you hear me okay?
Yes.
Great. So there's no time where it's too late necessarily, but definitely the sooner that we can evaluate a child for a biventricular conversion, the better. And the good thing is that on the basis of the echoes and MRI that have been done already, we can make this assessment very quickly as to candidacy for a biventricular conversion. We've had many patients come to us after their Fontan that we've been able to convert, but I would say the vast majority have come to us somewhere between the Glenn age and the Fontan age. And a lot of the children are being considered for Fontan, so they're about, let's say, 2.5 to 3 years old, where we're actually offering them the biventricular conversion pathway.
Excellent. So another question is, so is the opposite true? Is it that a chamber is too big and can be reduced, for example?
That's a great question. So the right ventricle, as you know, was designed to pump to the lungs, not to the body. And when the right ventricle is being used primarily to pump to the body, it tends to dilate. It tends to get too big and actually dwarf or squeeze the left ventricle. And so a lot of what we're doing in getting the left side to grow is actually to get the right ventricle off of the left ventricle. And so by changing the flow of blood and the pressures, less flow to the right ventricle, more to the left, more pressure in the left ventricle, less in the right, that actually allows the left ventricle to open up and be bigger, and doing the same thing actually is causing the right ventricle to be smaller. So we don't normally need to cut out part of the ventricles to make them smaller. We do cut out the inside of ventricles to make them bigger. But in the case of a ventricle being too big, usually just by redirecting the flow to where it's supposed to be and pressurizing what is supposed to be pressurized and lowering the pressure on the side that shouldn't be pressurized, or at least not pressurized as much, the net effect of that, to answer your question, is it actually reduces the size of the right ventricle. Did that answer your question?
Yes, thank you very much.
Sure.
All right, Jody, I think we are at time.
Okay, Dr. Salazar, thank you so much. This was so interesting and exciting, and we really appreciate you being on, and those of you down there at Memorial Hermann for being so generous with your time and with your talents and sharing you with us. So thank you very much.
Well, it's really our pleasure, and we want to convey a message of hope to all of your families and all of your children. Thank you.
Definitely do that. Thank you.